A quick hello before we dive in. My name is Dr. Michael, a practicing GP here in Auckland. I help international medical graduates prepare for the NZREX clinical exam through focused OSCE tutorials. My sessions include small group practices and personalized one-on-one mock exams with detailed and practical feedback to help you build confidence in communication, clinical reasoning, cultural safety, and managing those time stations. If you're on the journey towards registration and practicing in New Zealand, you're in the right place. You can find more information about my courses and upcoming sessions on my website. Let's get started with today's topic. Alright, so let's move into our first topic, history taking structure made simple. This is the foundation of every OSCE station, and once you understand the structure, everything else becomes much easier. So, a typical way of taking a history, my approach. I start by introducing myself to the patient and confirming their identity. Then I clarify the reason for the attendance today. For example, hi, I'm Dr. Michael. I'll be speaking with you today. Before we start, could I confirm your full name and date of birth, please? Thank you, and what brings you here today? Now, it's important that we ask the presenting complaint first, and we always ask by open question. And I let the patient speak first. Can you tell me more about what's been going on? When did you first notice something wasn't quite right? After the patient finishes describing the problem in their own words, my next step depends on whether the main issue involves pain or not. If the complaint is mainly about pain, I use the mnemonic Socrates, S-O-C-R-A-T-E-S. If the complaint is not pain related, I use the mnemonic Odipara, O-D-I-P-A-R-A. I always adapt the structure depending on the situation. Now, if this was a pain history, the important mnemonic is called Socrates. S stands for sight. Where exactly is the pain? Can you point to it with one finger? O stands for onset. When did it start? Did it come on suddenly or did it come on gradually? Was there anything that triggered it? C stands for character. How would you describe it? For example, is it sharp? Is it a dull pain? Is it a burning pain, throbbing pain? Is it tightness or is it cramping? R stands for radiation. Does it travel anywhere else or does it stay in one spot? A stands for associated symptoms. Have you noticed anything else with it? Like nausea, vomiting, fever, shortness of breath, sweating, dizziness, or anything else? T stands for time course. Is it there all the time or does it come and go? If it comes and go, how often does it happen? And how long does it last each time? E stands for exacerbating factors. What makes it worse? Does anything make it better? Like resting, changing position? Does ingestion of food make it better? Taking medication, using heat, using ice? R stands for relieving factors. Anything that makes it better. Severity, on a scale of 1 to 10, where 10 is the worst pain that you can imagine, how bad is it right now? And what is the worst it has ever been? So for symptoms that are not mainly pain, such as tiredness, dizziness, weight loss, sleeping issues, confusion, and urinary symptoms, I use the mnemonic Odipara. This is a very high-yield structure, but I still adapt it to the complaint. So O stands for onset. When did this happen? When did this begin? D stands for duration. How long does each episode last? For example, if it's dizziness, is it just seconds? Does it last for minutes or does it last for hours? I stands for intensity. How severe the symptoms is? How much does it affect you when it happens? Would you say it's mild, moderate, or severe? Progression. Has it been getting better, worse, or staying the same over time? A stands for aggravating factors. Does anything trigger it or makes it worse? Any pattern you've noticed, like standing up, exercising, under stress, or related to food, or specific time of the day. R stands for relieving factor. Is there anything that helps? For example, does lying down help? Does resting help? How about drinking fluids, eating, or any specific medication that you've been taking? A stands for other associated symptoms, any other symptoms that you've noticed alongside it. So just to give an example of how Odipara is applied, for example to shortness of breath. If I use the structure for shortness of breath, it might sound like, when did the breathlessness start? When it happens, how long does it last? How bad is it? Does it stop you doing normal activities? Is it getting worse, improving, or staying the same? Is there any specific things that you do that can trigger the symptom, like exertion, lying flat in cold air, or come into contact with specific allergens? Anything that you do that may help getting the symptoms better, such as resting, using any inhalers, or sitting upright. Any other associated symptoms like chest pain, any wheeze, cough, fever, any swellings around the leg? How about palpitations and dizziness? So moving forward, once I've explored the presenting complaint properly, the next two steps are, first, targeted differential screening, which are the red flags, and second, a brief systemic review if needed. The purpose of these steps is to rule out dangerous or connected diagnosis. This isn't just a memory trick. It shows the examiner I'm thinking like a safe doctor. I use a soft transition such as, before we move on, I'd like to ask you a few quick questions to make sure that we're not missing anything important. Differential diagnosis, differential screening. The exact red flag depends on the symptom, but most common include, have you had any fevers, unintentional weight loss, any lumps or bumps around the body, or any night sweats? Have you noticed blood anywhere, like blood in the urine, blood in the stool, or blood when coughing? Any chest pain, shortness of breath that's severe or sudden? Any recent travel, long journeys, or recent surgery which might indicate pulmonary embolism or deep venous thrombosis? So a brief systemic review if needed. If the picture is quite unclear or the complaint could involve more than one system, I do a short system review, usually 1 or 2 questions for each relevant system. For example, for neurological, any headache, any weakness, numbness, balance issues, or any visual problems. Respiratory, any cough, wheeze, or shortness of breath. Gastrointestinal, any changes in your appetite, nausea, vomiting, abdominal pain, or bowel habit changes. Genital urinary, any burning when you pass urine, any feeling of frequency, urgency, or changes in the urine. Skin and joint, any joint pain, swelling, stiffness, or any rashes around the body. So after completing all the information and the history taking on this part, I move into the rest of the history using the P-Maptosa mnemonic. So basically this means past medical history and the general background. I usually introduce it smoothly. Now I'll ask a few questions about your general health and background. Is that okay? P stands for past and current conditions. Do you have any long-term medical conditions, for example, high blood pressure, asthma, diabetes, or thyroid problems that I need to know about? Have you ever had any surgeries of being admitted to the hospital before? Have you ever had anything like this in the past? M stands for medication. Do you take any regular medications? Have you started or stopped anything recently? Or do you have used any over-the-counter medications, herbal product, or take any supplements? A stands for allergy, which is important. Are you allergic to medications or food? What kind of reactions do you get when you have these reactions? F stands for family condition. I always explain what I'm asking. Sometimes health problems can run in the family, so I'll ask a quick question about that. Any family history of heart disease, stroke, diabetes, cancer, or anything similar? Has anyone in the family ever been diagnosed similar symptoms like what you're experiencing right now? T stands for travel. Have you traveled overseas or anywhere unusual in the last few weeks or month, which can be relevant to hepatitis conditions, or any long-haul travel or journeys, which may indicate possibility of risk factors for pulmonary embolism and DVT. O stands for occupation. What kind of work do you do? Has this problem affected your work or daily functions? S stands for social background, and we can use the mnemonic DESSA, D-E-S-S-A. I transition like this. Now, I'll ask a few brief questions about your lifestyle. These can sometimes be really relevant to figuring out what might be going on. So D stands for diet. Would you say your diet is fairly balanced? E, exercise. Do you get any regular activities like walking? Or any exercise routines that you do daily? S stands for smoking. Do you smoke? If yes, how many per day and how long? For how long have you been smoking? If it's a motivational interviewing station, we can ask the patient, is there something that you'd like to talk about today? S stands for stress. Has anything been particularly stressful lately? A for alcohol. Do you drink alcohol? How often and roughly how much? I always include key practical questions. Who do you live with? Do you drive? And I keep in mind driving is especially important for things like seizures, blackouts, and significant vision problems. And finally, A for anything else. Before I summarize or move on, I always ask, before we move on, is there anything else you think I should know about, just in case I missed it? I always remind myself, I need to be flexible but still cover the main important parts. The depth depends on the case and the time. I should use transitions and sound naturally, especially when moving from the symptoms into a background history. I need to build rapport by sounding curious, warm, and safe. And I should use patient-friendly language. For example, I say conditions, treatments, and tests, rather than sounding robotic with words like history, management, and investigations. Now, there's a concept of what we call ICE. It's called ideas, concerns, and expectations. Why does this matter? Once I've understood the background with the P-MAPTOSA and I've explored how the conditions is affecting the patient's life, I then explore what we call the ICE, the patient's thoughts and feelings about what is happening. This makes the consultation more patient-centered and more complete. ICE will help me uncover fears or misunderstandings from the patient and clarify what the patient actually wants from the consultation today. And on top of that, this can build trust and emotional safety. Now, a lot of people will ask, when should I ask ICE? I usually ask ICE after P-MAPTOSA and after exploring the impact of symptoms of daily life. The more you practice, the more you're flexible where you put the ICE. For example, when you're taking history, you look at the patient, and if the patient seems to be quite concerned, then you'll use your ICE as the patient shows their cue. You can put ICE just after P-MAPTOSA so that you can get the feeling of always asking ICE when you take a history. If the patient brings up a concern early, I can acknowledge it and park it gently. For example, that is a really important question that you brought up. I'll come back to that in a moment after I ask a few more questions. Would that be okay? Now, asking ICE, you don't want to sound robotic. Initially, you may be sounding robotic, but as you practice, you want to sound like a real conversation. You want it to have warmth. For example, ideas. What do you think might be causing this? Concerns. Is there anything in particular you're worried that this could be? Expectations. What were you hoping we could do for you today? So after ICE, I respond supportively. Thank you for telling me that. It really helps me understand where you're coming from. We should always try to explore how the symptoms is affecting the patient's daily life. This is a key part of rapport and also helps shape a realistic and compassionate plan. It shows I'm not only treating the symptoms, but I'm treating the person. I usually ask about impact after P-MAPTOSA and ICE once I understand the basic clinical picture. The way to ask this, for example, how has this been affecting your daily life? How are you coping with it day to day? Has it impacted your sleep? Has it affected your work? Affected your appetite, or even relationships? Has it stopped you from doing things that you normally enjoy? I respond with empathy to whatever they tell me. That sounds really difficult to deal with every day. Thank you so much for sharing that with me. So I hope that helps, and that's it for today's episode. Take some time to practice this structure, and I'll see you in the next episode.